Hi everybody, welcome to my channel. Today let's talk a little bit about wound care. I've had people asking about that and I will find some visuals for you guys at some point, but we can just talk about basic wound care. We've talked about this before, but I'll talk about it again. Not sure what specifically people are looking for, but in the hospice setting, our wound care is more for comfort and to prevent infection. Before we get into it, I just want to start by saying that if there is any questions that you have, any concerns, please feel free to write them in the comments. I always read your comments. If you like what you see here, then I ask that you like, subscribe, and follow for more, and share if you think it would be interesting to others. The other thing is, nothing I say replaces the advice of a MD, and if it doesn't apply to you, take what resonates, leave what doesn't, like the psychics say. Let's talk about wounds. So when we're talking about wounds, basically, for any setting, a stage 1 would be a red mark that doesn't go away when you press on it. That's a stage 1. So if somebody has a place on their skin, namely pressure ulcers are going to be in places like the tailbone, our sit bones where we sit under our bottom, like under the cheeks, under your buttocks, where you sit, you can get pressure ulcers there. The heels are a source that you can get pressure, the back of the head, the spine, the shoulder blades, elbows, anywhere that you're not moving, you can get a pressure ulcer, especially if there's a bone there that is sitting against the skin, like elbows, heels. Oddly enough, you can get a pressure in the Achilles, and it is not an easy one to heal. The ankles, the toes. Some wounds are not really pressure wounds though, because there's different types of wounds that we see in nursing and in healthcare. I'm specifically focused on nursing, but we can see diabetic ulcers, we can see vascular ulcers that are caused by poor arterial blood flow, poor venous blood flow. So there are different types of wounds that you can see when you're talking about wounds. But a stage 1 is just a red area that doesn't go away when you press it. When you relieve pressure, it stays there. When you press it, it doesn't blanch. That's a stage 1. A stage 2 is a superficial opening in the skin. It's going to be either beefy red, pink, but just the top layer of skin is off. Or a blister would be considered a stage 2. A stage 3 is going to be going a little bit deeper. It might have some slough in there, might have some eschar, but you're able to basically see the base of the wound in a stage 3. And it is going into the fat, not necessarily getting down into the muscles and the bones. You start getting into stage 4s and unstageables when you start getting into things where you can't see. If you can't see something, it's unstageable. If you can't see to the base of the wound to see how deep it is, it's unstageable. If you have eschar, which is your dark brown or your black, hard, necrotic tissue, your dead tissue, this is often accompanied with a stage 4. And often when you're getting into stage 4s, you can see down into the muscle and into the bone sometimes. Sometimes you can see tendons when you're looking at wounds. And tendons are very hard to heal. When we expose a tendon, we want to protect it. We want to make sure that we keep it moist, because if it dries out, it's very hard to heal a tendon. At least that's what I was always told throughout my career by people who did wound care and that were wound specialists and wound certified. I have been a nurse for 25-ish more years, and I've done wound care throughout my career and seen many wounds. What you do see in wounds that are like stage 3, sometimes you can see slough. That is like stringy, white, yellow. It doesn't come off. So what can you do when you're looking at these wounds? Well, let's talk about it. When you are looking at a wound on the tailbone, on the elbow, on the back, you can absolutely you can have somebody debride those wounds professionally. You can use enzymatic debriders. We have things like Santil. We use Meta-Honey a lot. Sometimes your gels, your hydrogels, will do some autolytic debriding if you get a bandage on there and keep it in place. Sometimes you can put a dressing on and leave it on in place, like a Duoderm, for example. Believe it or not, if you leave a Duoderm in place and it stays in place, it can cause its own environment and do the debriding on its own. The body will debride that stuff if you leave a dressing intact. What we don't want to debride is heels. As nurses, we do not want to be debriding heels, feet, toes. We're not debriding those. Standardly in hospice especially, we are not opening that stuff. We're not trying to open that. If a doctor gives you an order to use a specific cream or treatment, or a doctor does sharp debridement, then you are following behind the doctor to do the care of that wound. You as a nurse cannot take your scissors out and cut off dead tissue. Please don't do it. Do not cut off calluses. Do not cut off dead tissue. I have seen in long-term care facilities where a nurse has done this, and it is outside the scope of our practice if we are not trained and delegated to do those types of tasks. A registered nurse can be wound certified. They can be trained to do sharp debridement. They can be trained to do those things. However, it's still going to need a doctor's guidance. We can't just go cutting stuff off. Had a patient that I had seen had diabetic wounds and a callus on the foot. When you are looking at wounds, you want to be, especially with diabetics, you want to be assessing their feet every shift. Every time that you go around a diabetic, you want to be looking at their skin, but especially their feet, because they can get sores on their feet. And sometimes there is something nasty lingering beneath the callus. However, don't take the callus off. Don't do it. I'm telling you this because I have seen a nurse lose their job for doing this and acting outside of their scope of practice. Always we want to consider what the doctor's order says, and we always want to consult with a doctor when we're talking about wound care. Some doctors have preferences. Sometimes you have a protocol that you can use, and you can suggest this protocol to the doctor. Sometimes you're collaborating with a wound doctor who is also managing that wound. In hospice, we often do collaborate with wound care because there is wound care that comes into facilities and does sharp debridement and writes new treatment orders. Sometimes they culture those because, you know, sometimes a wound can get infected. There's all kinds of things that could hinder a wound's healing. So what kind of wound are we looking at, and how do we treat it? That's the question. When you're looking at a stage 1, you're going to offload pressure. You want to make sure that you're offloading pressure. I would like to share this with you. Statistically, a pressure ulcer, and there may be newer definitions to this, but standardly, a pressure ulcer can develop in 2 to 6 hours of not moving, especially in a highly compromised patient who is not eating enough protein and nutrients to sustain any kind of healing to their skin. So a pressure ulcer, and I'm talking about a really nasty one, can develop in 2 to 6 hours. I'm not just talking about a stage 1, a stage 4, a DTI. Those things can happen if you're not turning and repositioning people. But when you have a stage 1, your first line of treatment is going to be offloading the pressure. You want to turn and reposition a person every 1 to 2 hours. If they're compromised, maybe you have to move them more. If you think about it, when we sit in chairs, when we lay on bed, when we lay on our beds, when we sit in chairs, we never just sit still, do we? We shift. We shift our weight when we get uncomfortable. If we're not comfortable in the bed, we turn from side to side. We move. We move our legs, we move our feet, we move our bottom, and we sometimes stand up and walk around. A person who has impaired mobility or an impaired immune system, or they are not getting enough nutrients, they're not going to be able to do the same things. They're going to be weaker. They're going to have a higher occurrence of breaking down. Whereas you or I, who are moving around, are not going to break down if we maybe lay on our bed for 2 hours. But you know, sometimes you've seen, if you lay on a blanket or something, you'll see an indentation of the blanket on your skin when you wake up. But think about this from the perspective of somebody who has poor circulation and poor nutrition. Now maybe they have a wound where that blanket was indented into their leg or into their bottom or into their back. So you really have to think about that. Another place that you can get pressure ulcers, and I just want to share this, is that when you are using oxygen tubing or masks on the face and behind the ears, you can develop pressure wounds. in those areas due to the tubing. So when we're also looking at a person who is compromised, we also want to consider padding those and releasing those and checking the skin underneath them at least every shift and shifting it around if we can. A lot of patients that are totally with it, that have to use oxygen, will take the oxygen off, put it back on, take it off, put it back on. Your ears get sore when you wear oxygen for a long time. You can get sores in the nose here, and you can certainly get a sore where the mask is sitting against the face, especially if it's tight or, you know, a person isn't moving around. So think about that when you're thinking about pressure ulcers also. So people want to know, what does a stage 2 look like? A stage 2 is, like I said, that superficial layer of skin is off. This can be bright, beefy red. That's healthy. We want to see red when we're looking at a wound bed. Or it can be that shiny. That isn't necessarily what we want to see. We do want to see that red granulation, beefy looking tissue, because that means that there's good circulation there and there's wound healing. If you see blood, you're seeing circulation and it's going to heal. In a stage 3 with slough, like I said, you might see some brown or yellow in addition to the shiny pink. Sometimes you'll see some of that beefy red, but I'll tell you something that wounds do on the edges. When you clean a wound, you maybe want to take the gauze and clean a little harder around the edges to keep the edges from rolling, because we want to keep those edges irritated a little bit. Not hard, not hurting people, but a wound specialist one time told me to rough up the edges a little bit with a gauze. That helps to keep the edges from rolling in, because if the edges roll in, then the wound won't close. I think I've done a video about this before, but I'm just going to do it again because people have asked for wound care, and so we'll talk about it again. In a stage 4, you might see really deep into the muscle. There might be tunneling in these wounds. There might be undermining. So you want to make sure that you're seeing how deep those wounds are. Sometimes we do pack wounds, and if you're packing wounds, you might be using something like alginate. I have used iodoform and packing strips in surgical type wounds. That's another type of wound that you might see in healthcare, as a surgical wound that healed and it didn't close inside, but it closed on the outside. So now you kind of have to pack it to give it something to grab onto so that it can heal inside. And this is something that you do see sometimes, is packing strips. But in wound care, where we're taking care of pressure ulcers and things like that, what we are going to do is use an alginate a lot of times. And something that was told to me that I keep in my brain is fluff, don't stuff. So don't pack a wound so tightly that it doesn't have room to grow closed. Because if you put the materials in there so tight, then it may get deeper and it may not have anything, you know, the collagen that's forming in the wound to grow across the wound is not going to have something to grab onto and to grow in if it's just packed really tight. So don't pack wounds really tight. Fluff, don't stuff. Alginate is really good because it pulls apart. There's alginate ropes. There are alginate squares. I will tell you that one thing that I learned from a nurse practitioner who was a wound certified nurse practitioner that came in and did our sharp debridement in a facility years ago. She would cut the alginate that was the square into a spiral and pack it that way and use it like a packing strip. Again, you're not going to pack it super tight. So what are the types of things that we put on wounds? So we want to clean the wound from the wound bed and out. We don't want to be crossing from the skin into the wound. We want to clean the wound bed and go in a circle and come out. And we want to clean the skin around the wound last. We don't want to be putting what's on our skin back into the wound bed, because that's how we can get bacteria into our wound. We have bacteria living on our skin. We have staph living on our skin, and people don't realize this, but your skin is dirty. So you can infect a wound by cross-contaminating, by putting what's on the skin into the wound bed. So you want to use a wound cleanser, you want to use saline, you want to use whatever the doctor has ordered for you to clean the wound. And understand there are certain wound cleansers that don't work with certain products. For example, if you're using Santil in a wound, this is an oldie but goodie, you should not be using wound cleanser to clean that wound. You should be using saline. They interact adversely, and so it changes the way the medication works. So don't use wound cleaner in a wound bed that you're putting Santil into. An oldie but goodie is a wet to dry dressing. This is not something that we commonly do, but it is something that you can do in a palliative situation. But a lot of times what I see people using is honey. So what you want to do around the wound, peri-wound, is use something like skin prep to protect the skin from drainage or from products, from the debriding products that you're using. Honey is pretty amazing. I didn't like it when it first came out, but I love it. And it's so hard to find now because everybody's using it. So an alternative for using honey is the gel. Hydrogel is an alternative. Silver hydrogel or hydrogel. Make sure your person's not allergic to silver. Always make sure that you're checking the allergies of your patients before you're putting something onto or into their wounds. You want to make sure that when you're using alginate, that you're putting the alginate into the wound bed. So you're going to cut it to size, or you're going to pack it in there, but you're going to make sure that you don't have alginate hanging out on the skin. We don't want the alginate on the good tissue. We don't want the meta honey on the good tissue. We don't want the Santil on the good tissue. We want the Santil on the wound bed, on the necrotic tissue. We want the alginate in the wound bed, not on the healthy tissue. And then you're going to put a secondary dressing on. That could be a foam dressing, that could be gauze, that could be an ABD pad. So here's the thing, foam is a wonderful, wonderful invention, and they have many different types of foam dressings that you can use, and they are designed to stay on for up to 7 days. If you have a wound that's really heavily draining, heavily exudating, then you're not always going to be able to leave something on for 7 days. Sometimes you're changing it every 3. But the thing is, you want to leave a dressing like that alone. We don't want to be opening that and disturbing that environment every day. So if you're going to be changing a dressing every day, you want to consider using something like gauze or an ABD pad, not foam. Foam needs to do its thing. It needs to stay in place for a minimum of 3 days and a maximum of 7. And that really is going to depend on how the wound is doing. You do want to be assessing that bandage and making sure that the drainage isn't excessive. You want to be making sure that it's adherent to the skin, that it's not open, that there isn't something getting into the bandage such as BM or urine if it's on somebody's bottom. We want to make sure that that bandage stays closed. So in hospice, we are putting those bandages on, and the families and caregivers are managing those dressings. So we want to make sure that we're teaching them how to manage those dressings and what to do if that dressing begins to peel up or needs to be changed. So that's a really important part of your education. You can use Santil on a stage 3. You can use it on a stage 2. I've seen wound care doctors continue to use Santil for quite some time. I used to feel really nervous about using Santil on healthy tissue. I prefer Meta Honey when you're talking about something that's turning into stage 2. You can kind of use Meta Honey through the whole process. You can use alginate with Meta Honey. It's pretty versatile. With your gels, you can use those with alginate as well. You just need to be careful about what kind of cleansers you're using and make sure that nothing is interacting. For example, sometimes you're going to use charcoal type dressing for odor control, or Dakins. I don't know which way is correct, but it's your bleach smelling solution. Your Dakins solution is used when you have some odorous wounds, and you can't use that with, for example, silver alginate. You can't use Dakins and silver alginate or silver hydrogel together. You can't use silver and Dakins together. They are contraindicated together. So anytime that you're looking at a treatment, when a doctor gives you an order, you want to make sure that you know what the person is allergic to, how to properly clean that wound, what to put inside that wound, and what to put on the top of that wound. We want to be using barrier creams on our skins for our patients. That could be something that is zinc based. If it has a lower concentration of zinc, then usually your CNAs, your home health aides, can apply it. If it has a higher concentration of zinc, then it's considered a medication and the nurse should be applying it. That is actually true. But there are a lot of things that we can put on the skin to protect it that are not zinc based. So you don't always have to use zinc. Sometimes they have things on the market that are similar to, they have lanolin in them and different things like that that are really good on the bottom. And the thing you want to remember, keep in mind, if you're using something like zinc on a superficial stage 2, for example, you want to make sure that when you're cleaning someone's bottom, first of all, when you put zinc on somebody's skin, it should be like buttering bread and not like icing a cake. And it should not, what you're going to do is just wash the top layer off. We're not going to scrub all of the zinc off when we're using zinc. We want to make sure that we're not scrubbing the skin, because then we are going to be irritating the skin. So the thing that I see about zinc is people have a tendency to want to clean it all off. That is not the way it's designed to do. It's going to leave a residue, it's going to leave a film, it's going to leave a protection. You just want to get whatever's soiled off of the top layer and clean the person. And the goal is not to scrub it all off. And then you're going to gently reapply some more. But you do want to clean your patient's bottoms. You do want to clean them good, but we don't want to scrub until we get all the zinc off. There will be some residue left from the zinc, and that's okay. It really is, I promise you. At least that's what they tell me in all the years. But like you're buttering your toast, not like you're icing a cake. That's what you want to know. You don't want to put so much product on that you're going to have to scrub it off too. You don't need that much product. Now, what other kinds of wounds do we see? So we do see diabetic ulcers, we see arterial wounds, we see venous stasis wounds. Your venous stasis wounds are your sloppy, messy, irregular wounds. They drain a lot. They drain a lot. And they look really yucky usually. And so with your venous stasis ulcers, you can use alginate and things like that. I will tell you something that I had good experience with is light compression. And also you want to make sure that somebody's had ABGs and that we know what their circulation is before we start sticking an ACE wrap or TED hose on them, if the doctor says. But what I have seen used is we did use the Zeroform or petroleum gauze or that type of thing on your venous wounds, and then your secondary dressings. So I don't know, it worked whenever years ago we would make sure that we were lotioning up people that had venous insufficiency. Sometimes they have that staining in their legs, that discoloration in their legs, and so you want to make sure that you're keeping their legs clean and moisturized too. You want to make sure that you're moisturizing feet and legs, but also make sure that they're not walking around with moisturized feet on the floor and falling, just as a sidebar. Arterial wounds are those wounds that have a perfect circle, for example, and they look like somebody punched it out. That is high, and they're not going to be draining as heavily as your venous wounds. Diabetic wounds, you're going to see those on the feet a lot. Those are going to be on heels, toes, on the bottom of feet. And they can have a various appearance, but just know that when you're looking at a wound that's arterial, venous, or diabetic, you're not going to be staging those. And then there's something called a deep tissue injury, and it will turn into something else. And that is something where you'll see somebody, maybe they stayed on a surface for too long and they laid on a blanket. I've seen people on a bedpan, and it's very unfortunate. Or I will tell you that those heel boots can cause wounds on the feet. So we want to be making sure that if we have devices that we're using for pressure relief, that we're moving those around as well. And we want to make sure that we're not leaving a person on a bedpan, that we're making sure that all the wrinkles are out from under them as best as possible, because if they're laying on a wrinkled pad, that can cause a DTI. People have really fragile skin. What this looks like is it looks like a big purple wound. It's just something purple that developed that wasn't there before, and it's going to open, and it may be really deep when it does. So that is a DTI. Then you have moisture associated dermatitis. So that can have some openings in it too. It can have some like spotty opening in it, and that is your person that is incontinent, and even though you're cleaning them and things like that, they're still staying moist or they're sweaty. They can get a dermatitis, a moisture-associated dermatitis on their bottom and in their folds and in the front. So you want to make sure that that is where you're applying skin protectant to protect those people. There are antifungal powders. Sometimes people get fungal rashes that can cause wounds. You want to make sure that you are communicating those things to your doctor so that they can order the best treatment that the patient needs. And in this day and age in hospice, we do have secure platforms where we can actually do a video chat or, have the doctor get a visual of those wounds, compared to years ago when you'd call the doctor on the phone and just ask for a treatment. Again, some of your places may have a protocol for how they want to treat wounds. They may have a certain set of supplies. There's always interesting things that you can do with wounds, but basically you want to make sure that you are consistent with your wound care, that you're preventing infection, and there is nothing more satisfying than seeing a wound heal. Tell me about some wound care experiences that you had. Tell me about some things that you're curious about with wound care. Would you want to talk about wound vacs? We can talk about that. I would love to talk more with you guys, and I thank you so much for watching, and I hope to see you soon. Bye-bye.